Great. Thank you everyone for attending today. Hello and welcome to our October Tea Talk. We will be talking about the importance of pelvic floor physical therapy before and after excision surgery. My name is Allison Landolt. I am the president and a co-founder of the Endometriosis Foundation of Houston, or EFHou, as we like to call ourselves, because I think it's how we all feel about endometriosis. EFHou is the first and only Houston area nonprofit dedicated to endometriosis awareness, education, and advocacy. We have a monthly speaker series called Tea Talks, and that brings together professionals in the field of endometriosis with patients for an hour of education and empowerment. So today we are joined by our chairwoman, Maria Mamora, who will help moderate the talk. She has a super important special announcement at the end of the talk. So please make sure that you stick around for that. Because we've been keeping secrets and you want to know what they are. We're all very excited. And then we are going to finish out the talk today with a giveaway of the 86 Endo Weekly Planner, which is an amazing tool for helping people to track their symptoms, keep track of what their triggers are. It's a really valuable tool that I myself use and love. So we're going to be giving that away at the end of the talk as well. We are joined today by our guest speaker, Dr. Karen Kowenski. Yes, hi. Karen Kowenski is a pelvic floor physical therapist offering physical therapy services in Houston. She is a certified clinical specialist in women's health and the founder of Empower Yourself PT, a pelvic floor physical therapy practice dedicated to meeting you where you're at. Empowering patients through confidence and care, Karen believes that making small, realistic changes can help you meet your goals. With over 10 years of experience treating orthopedic and pelvic floor conditions, she looks beyond just the pelvis to take a full body approach. She treats a wide range of pelvic floor symptoms, including abdominal scar pain and restrictions, painful intercourse, and more. She also serves on the advisory board of the Endometriosis Foundation of Houston. And I think we can all agree that her most important qualification today is that she used to be my pelvic floor physical therapist. So I'm really excited to have her here and to be able to share her with you guys today, with all of you today. Thank you so much, Karen, for joining us.
Thanks for having me.
So I think today we're going to have more of a discussion. So if people would like to post their questions or unmute yourself if you have a question while Karen is speaking, then you can do that as well. Absolutely. And then we have, we'll open it up for a little bit of a Q&A at the end. And we also have some questions that people had submitted prior to the talk.
Yep.
So I'm going to hand it over to you.
Yes. Okay. Yes, just to reiterate what Allison says, I much prefer a conversation/discussion rather than just like talking at the screen. So if you have questions, just, type them in or unmute yourself, whatever you prefer. So I've been a physical therapist for about 12 years. And just like Allison said, everybody told me when I started being a physical therapist, like finishing school and everything, that you have to do, is everybody seeing what I'm saying?
Yeah, just a second.
That's okay.
Okay, we're good.
Okay. Everybody when I say everybody, I mean other physical therapists said you can't just do pelvic floor, you have to do orthopedics. And I didn't want to do orthopedics, right? Thank you, Maria. But I did it anyways because that's what everybody told me, and I was young and I just listened to everybody else. So after about 5 years of doing orthopedics and pelvic floor, I went just into pelvic floor because I was like, that's all I want to focus in on, and I don't really care about everything else. But sure enough, with time, and as I started seeing more and more complex patients, I realized that you can't forget the orthopedics, and the orthopedics affect the pelvic floor, and the pelvic floor affects orthopedics. So yes, I do both. And people ask how you can do both. And unfortunately, those senior PTs were right. You have to do both. So I tend to look at not just the pelvic floor, but I describe the core as a soda can, right? And everybody like in me social media talks about the core as like the six-pack muscle, the rectus abdominis, like the sexy muscle in the front. The core is actually, I want you to compare it to a soda can, or if you prefer, a champagne bottle, whatever it is. In the front, you have your abdominals. In the back, you have your back muscles. On the sides, you have your obliques. At the top, you have your diaphragm. And at the bottom is the pelvic floor. So the pelvic floor is the bottom of that soda can, okay? And it's sort of a situation that's equal and opposite in pressure. Everything has to work together. And if there's an imbalance, the soda can kind of smushes. So what happens if you shake the soda can and you open it at the top? All the soda spews up towards the top. So that would be the equivalent of like a diaphragmatic hernia, which is super rare. You could have an opening in the soda can in the front. What a lot of people talk about with that is diastasis or some kind of abdominal hernia. It could be an injury to the front of the abdominal wall with surgery, even done laparoscopically. It could also be excess scar tissue from a laparoscopic surgery or even just a prior surgery in general. You could have back issues from the back of your soda can not working properly. That could be sciatica, generalized back pain. It could be any and all of the above. The other thing is that it can be the bottom of the soda can. Sorry, the screen just changed again. Does it matter? It's okay. So the bottom of the soda can could be the pelvic floor. And again, the bottom of the soda can open or it can be really closed. Now, typically with pelvic pain patients, like endometriosis patients, the bottom of the pelvic floor is very tight. So if you're thinking of a soda can, what happens if the bottom of the soda can just kind of smushes and kind of squeezes shut? Do you see how there could be increased pressure in the back and in the stomach and in the front? Yes, maybe. Okay. So the other thing I wanted to, if we're talking about the soda can, people ask, well, how do you know if my soda can is not working right? And my question is, well, what are your symptoms, right? So typically, if you're having pain with intercourse or pelvic pain, a pelvic floor physical therapist is going to assume that there's something going on with your pelvic floor. It may be tight. It may have trigger points in it and knots in it. It may not be able to relax so well. If you're having urinary symptoms or bowel symptoms, that's also a pelvic floor indication. A lot of endo patients are diagnosed with IBS. IBS mixed, IBS-C, IBS-D, it doesn't really matter. IBS is also a dump bucket for all GI symptoms, really, right? So if you have kind of constipation, diarrhea, it's kind of dumped between the two. Urinary issues, urinary frequency, or bladder pain is also a question of, is it the endo or is it the pelvic floor? Well, imagine if you do have endometriosis. I'm sorry, Maria, I don't understand. I don't know. Keep going. Cool. Okay. So, okay. I forgot where I was. Help me out.
It's okay. I'll feed the questions. So if we have anything that comes up,
Pelvic floor pain.
but you were talking about pelvic floor pain, yeah.
Thanks. Okay, pelvic floor pain. So let's assume, everybody in this room has some form of endometriosis. Okay, so if you do have endometriosis, I want you to think of your soda can and think about little blips of like goop growing inside of your soda can and growing from the center out. So growing up towards the top, towards the front, towards the back, and towards the bottom. And it can even spread down into your hips and back. We don't know that for sure. But if that's the case, you can see how it's going to affect your bowel bladder issues, your pelvic floor issues, your breathing, and the diaphragmatic movement, the pelvic floor movement, all of those pieces. Okay. So the question is then, one, is it endometriosis? Is it not? Two, what are you going to do about it? So pelvic floor physical therapists don't actually treat endometriosis. I want to make that super clear. The only way to treat it is to remove it with surgery. Okay. Excision is the way to go. But what physical therapy can do is help you treat the symptoms either caused by endometriosis or indirectly caused by endometriosis. Now, people are like, what does that mean directly or indirectly? And this is kind of where we move into the pre-surgery component. So you may have endometriosis, okay? But you can also have an overactive pelvic floor. And if a surgeon goes in and removes the endometriosis, that doesn't necessarily mean your pelvic floor will relax and return to normal, whatever normal may be, right? So you still need to address the musculoskeletal components. Okay. So an example I give is a lot of endometriosis patients have pain with intercourse, pain with penetration. Okay. If a surgeon goes in and removes the endometriosis, well, that may go ahead. No. Okay. That will help with your endometriosis pain, but that may not help with your pelvic floor pain or your pain with intercourse. So one of the big things that we talk about is treating the patient before surgery and after surgery. Okay. So if somebody comes in before surgery and they say, okay, they have a surgery date whenever it is coming up, the question is, what are your symptoms? So I would have you fill out a questionnaire that would break down your bowel, bladder, sexual pain symptoms, and all those questions. And I would sit down and talk with you and explain that there's a good chance a lot of your pain is going to get better after surgery, but there's also a good chance that some of your pain won't get better after surgery. And some women don't like to hear that. They don't like to hear that. But they're so stuck on this idea that the surgery is going to fix everything. And it doesn't always do that. I did see somebody a month or two ago who had surgery and 90% of her pain was better, except she still had some urinary frequency. So we had to address that. And that was something we addressed post-surgery, obviously. But what can physical therapy do pre-surgery? So a lot of it is helping you manage your pain. Okay. So you may get in to see a doctor in January, but he or she may not have room to see you or to actually do surgery on you for 4 to 6 months. So what are you going to do for those 4 to 6 months? It's not as simple as a heating pad. We talk about, a lot of physical therapists talk about diaphragmatic breathing, pelvic floor movement. Can you contract the pelvic floor? Can you relax the pelvic floor? A lot of the times when we're in a flare, we kind of bend over in a fetal position, you stop breathing, or you kind of hold your breath through the spasms. Well, guess what? Your pelvic floor is tensing too. Okay. And when you stay like that for 4 or 5 days, it's not helping. The pelvic floor is getting tighter. If it's really painful to defecate, then your muscles are going to tense in response to that. Okay. So some of it may be, how are you going to pee and how are you going to poop without pain? Okay. And that can be a combination of squatty potties, which I'm sure, does everybody have a squatty potty? I hope so, right? Yes, thank you, Allison. I hope all of you have a squatty potty. We have 3 bathrooms in my house, and we have 3 squatty potties in my house. Yes, thank you, Chris. Yep. Excellent. Everybody, the squatty potty is the best thing. If you don't want to buy a squatty potty, you can use 2 regular stools that are like $10 each. It doesn't have to be serious. Okay. Right. And technically, as a pelvic floor physical therapist, it is outside of our scope of practice to recommend different things to kind of control the consistency of your stool. But there are definitely pieces that I can recommend, such as I'll definitely have you guys do a food journal, a bladder journal, a bowel journal, different things that will help you control the consistency of your stool. Sorry. So a lot of women will say their stool is really hard and rocky and pebbly. Well, how do we make that softer so that it passes through the rectal canal better? The other thing we do in physical therapy is also general strengthening, knowing you're going to have surgery. How do we strengthen your back muscles, your core muscles without flaring your pelvic floor? Different techniques I use are a lot of mobilizations. I use a lot of dry needling to release trigger points. Sometimes those muscles that have been tight for years don't really want to release. So dry needling is a really effective tool to release those muscle spasms. I really like that technique. The other concept that I like to talk about is central sensitization. Central sensitization is sort of a new topic in the pain science world, but it's sort of not. Now, the idea is and I'm going to simplify it, let's say you have pain in your belly button, okay? And it starts one random day, and there's a signal that goes from your belly button to the brain that says, ouch, ouch, there is pain. There's pain in my brain from my belly button. And we do different things to try and make our belly button pain get better, but it doesn't work. And our belly button pain, sorry, I got to turn that off. Our belly button pain does not get better. So this pathway that's sending signals to the brain and saying the belly button pain is still there, pain is still there, it's still there, it's getting louder and louder and louder, so that the brain is now not just perceiving pain in the belly button, but perceiving pain in the hip bone, in the pelvis, in the back. And we start taking different pain pills, and that messes with the neuroanatomy. Also, because our belly button is hurting, we're bending over a lot more in a fetal position. We get more constipated, all these things. And that is sending more negative feedback to the brain that's saying, oh, I'm in pain, I'm in pain, I'm in pain. Okay. And it doesn't get better. Okay. So when you have surgery, you're removing the trigger, assuming the trigger is endometriosis. Okay. So now the trigger that caused the belly button pain is gone. But now we still have those signals going to the brain saying, hey, I'm still in pain. I'm still in pain. I'm still in pain. And the brain is telling you that you're still in pain. Now, I would argue in a sort of funny way, like, oh, it's in your head, haha, but it's not in your head. I mean, there has been a change in your neuroanatomy, which is making you believe the pain stimulus is still there. But hopefully surgery has removed it. So with physical therapy, a lot of what I do is neural desensitization, where it's like touching your belly button. Does that really hurt? Or are you more afraid that it's going to hurt? Are you going to move in a certain way that is going to make it hurt? How do we relax the muscles around the belly button and around the pelvic floor to keep the muscle relaxed? Okay. All of those pieces are things I educate on pre-surgery, but also more address post-surgery. And also post-surgery, we're dealing with what's happening after the surgery. So again, jumping back to pre-surgery, one of the last visits I have with a patient before they go into surgery is, well, what are you going to do post-surgery? So most women after surgery, I'm so sorry, Allison. Was there a question? Yes. Okay. 1 minute.
Sorry, I had to figure out how to unmute myself. Yes, so we have a question that came in.
Okay.
If someone doesn't experience pain with intercourse or have any bladder or colon issues, but you're having popping in the pelvic area, specifically the pubic bone, would you suggest that they seek PT?
Yes. Does this person have endometriosis? And is
Yes.
it pre or post surgery?
This particular person, I believe that she is post-surgery.
Okay. Popping in the pubic bone is sort of a hallmark sign for pubic symphysis dysfunction. Okay. Which is not really commonly associated with endometriosis. But I do commonly see it in my more pregnant and postpartum population. That doesn't mean it is or is not related to endometriosis, because frankly, it doesn't matter. But it's most likely due to an instability in the pelvic girdle and absolutely can be treated with pelvic floor physical therapy. For somebody who's popping in the pubic bone, I don't know if this person is on the talk. Yes, the easy trick I have for that person is to walk backwards. So if that person is like walking or going up and down the stairs or whatever with pain, try going backwards, like heels first. I know that's really weird, but it's not going to fix it, but it is a temporary band-aid. And that's kind of how I operate, in that I will give you guys a temporary band-aid and then I'll actually fix it, because the reality is you want to be pain-free. Does that make sense?
So she said, thank you. This issue is typically before or right after her period.
Interesting. Popping in the pubic bone. Right before and right after. Right?
Mm-hmm.
And that's her only symptom?
She says it's almost as if things are resetting.
Before and after the period, but not during the period.
Yeah. Let's see. Never during.
I would honestly say I don't know. And I'm okay with saying I don't know. If I were seeing you, I would want to see you right before and right after your period. Okay, I'd be curious. When you are about to have your period and right after your period, your hormones are fluctuating a lot, which can create a change in elasticity of the tendons and ligaments. And so in theory, I guess things could be popping in and out of place. I'd have a lot more questions for her in terms of like what she does for work, also what she's doing before her period, during her period, after her period. If there was maybe like an ergonomic component in there somewhere. But that's interesting. It absolutely is something that's pelvic floor related, or at least something going on with her inner thighs or hips even.
Very interesting. Yeah, I think that that's kind of a tough one to know without like actually seeing the person. But I think one of the things that I love that you just said is, I don't know. And as patients with endo, I mean, there's a lot that people don't know, but to hear someone admit that they don't know and say, but we can try to figure it out is so helpful.
I don't know a lot of things, just FYI. But I do know a lot of things too, right? I like playing detective, and I like kind of a good physical therapist is going to ask you more questions, right? They might answer your question with a question. And they'll be like, well, tell me more.
Yeah, it's part of the exploratory process, I think.
Absolutely. Yeah.
Yeah. We had another question. Is it okay to keep going with the questions, or did you want to get back to where you were at?
No, questions are good. Questions are good. I think my talk was sort of all over the place. I'm much better with this.
We've had a few interruptions today. One of the, fun troubles of having a publicly available Zoom, as we've had a little bit of trolling today. So thank you so much
We
for
like
sticking with
trash.
us.
I always tell
Yeah.
people, or my people, whoever I'm in the room with, I'm like, look, I know this is your first time meeting me. I know this is a little weird for you, but for me, it's not weird. And also everything you say on these four walls is not TMI, and I've always heard it before. I've never not heard it before.
Yeah. So we had somebody ask about pelvic pain after hysterectomy. Is that something that's pretty common? Is that something that they should be seeking PT for? Can that help? And can you talk a little bit about how that could help?
Right. Yes. So again, there are like specific categories about that that can make intercourse painful. So the question I would also ask is roughly how old is that person? Do they have their ovaries or not? Is it a partial hysterectomy? Is it a full hysterectomy? Also, was the surgery done transabdominally or transvaginally? And you may not know the answer to those questions, Allison. Maybe not, maybe.
Late 40s, transvaginally, kept ovaries.
Okay. Does the person have a vaginal cuff? Did they remove her cervix?
Yes.
Yes, they removed her cervix. Yes, she has a vaginal cuff.
Yes.
Okay. So a vaginal cuff, what they do is they take out the uterus and they take out the cervix, and then they literally put a cuff at the top of the vagina, so the most inner part of the vagina. It does shorten the vaginal canal. So some of those women will complain of a deeper penetration. And the reality is physical therapy is not going to remove the cuff, okay, because your surgeon put that there and I can't change that. And that's not going to change. But sometimes there is a lot of scar tissue around the vaginal cuff, and I can release that. And that will help decrease your pain. Will it make it a 0 out of 10? I don't know. Okay, that it really depends on the person. Also, she said transvaginally, right?
Yes.
Yes, I'm very paper and pen oriented. I'm not a great listener. So like if you come see me, I'll like constantly be writing things down. I'm writing little keywords, and you'll see I always have a paper and pen with me. The other issue is with that surgery is those obturator muscles, which are the muscles that connect the hip bones to the pelvic floor, tend to get very tight. Okay. There also can be some scar tissue because they tack the vaginal cuff up to the sacrum. Okay. And they do that around the rectum. Okay. So some women will complain of constipation after that surgery. My question would also be late 40s, when did your mom go through menopause? If she went through menopause a little bit early, then you may need some kind of topical estrogen. If your pain is more superficial, like pain with penetration or pain at the entrance, I would also want to take a look at your vulva. Is it red? Is it irritated? Is it not? The short answer to your question is yes, I can help you. The long answer would be I would probably want to get a copy of your surgical report and see what they did, what approach they took, and where you're going from there. Also, consistency of stool. If your rectum is full, it's going to make the vagina a little bit smaller, right? Because there won't be as much room for the vagina to expand for the penis to penetrate. Also, I know this sounds kind of silly, but we talk about intercourse ergonomics. Believe it or not, there are different positions that are better for deeper penetration, more superficial penetration. And yeah, like there are better positions pre and post surgery that are super important to talk about.
Have you heard of the Onat?
Yes.
What are your thoughts on that?
I have heard good things about the Onat. The Onat was originally developed for women with more of like a vulvovaginal condition. So I'm sure there are women in this group who have this called vulvodynia, vestibulodynia. And the idea is those women more have pain with initial penetration, but then once the penis initially penetrates, they're fine. The deeper penetration is fine. It's the beginning. I always call it like a ring of fire. They just have to get through the gate. Okay. So the Onat allows for more of a superficial penetration. The idea is that the penis is going inside and he doesn't have to penetrate as deeply. Okay. And it helps protect the opening. But a lot of deeper pelvic pain and more chronic pelvic pain patients have used it. I heard that it helps. Is it the same thing? No, but it's definitely an option. I tend to focus more on proper lubrication, proper foreplay. So just everybody being in the mood for it, and also making sure your pelvic floor muscles are relaxed. So that can include stretches and breathing, whatever it takes beforehand. It can include dilator work beforehand if you're an appropriate candidate for dilators. I know that kind of takes the romance out of it. But I think that's better than the Onat. But I do like the Onat.
Yeah, so it sounds like this is situations where, maybe you have options depending on where you are in your pelvic floor therapy journey.
Right. So a lot of younger women, I think, who have had pain with intercourse for a really long time aren't really excited about intercourse. They're not I don't want to say they're not motivated. There's a negative association, there's fear, there's anxiety. And it's like, if every time you put your hand on the stove, you burn your hand, why would you want to keep doing that? Like, where's the motivation in that? There isn't. But obviously this isn't the same thing. So if we can work on more foreplay to at least, because with more foreplay, with arousal, more blood flows to that area and then the muscles do relax. Another thing I do is I ask the patient to bring their partner in. Whoever your partner is, I don't know, I don't care, but bring them in and I can teach him or her how to do the manual releases on you prior to intercourse. Now, that maybe you have a stubborn spot that needs to be released. Your partner comes in, I teach him or her, he leaves, we keep going with our session. Now, a lot of women will be like, well, wait, so my partner helps me release a muscle and then we have sex. That's really awkward, Karen. And I'm like, no. I have arbitrarily decided like a 2-hour window. That is totally what I've decided. There's no research to support that. But I think that creates enough of a barrier to like at least try and make it more romantic. So I'm just totally throwing out numbers. So it's like 7 p.m., do a manual release. Cool. You do your thing. You can take a shower, you can eat dinner, whatever, and then you guys can try and have sex afterwards. I know that's not perfect, but we're not going for perfection, right? We're going for better. Perfection is really hard to achieve. And I honestly don't believe many couples have like a perfect mess-free, like fabulous orgasm galore intercourse. That's just not real life. And if you do, like, awesome, more power to you. But like, I just don't think that's real.
It's not all like what we see on TV.
I know.
And that's okay. I think setting realistic expectations for what sex is for you and for your partner is so important.
Absolutely. I don't know, has anybody seen the Thomas Crown Affair? It's kind of an old movie. I think it's from the 90s. But like they're basically having this crazy, intense, like sexual experience on the staircase. And you're just like, how are they doing that? Like on the staircase. Yeah. And like, they're like going to break their necks. But yeah, exactly. It is managing expectations. And also the idea is once you have a positive experience, you're more likely to try it again and again and to try different things, right? Like if the stove isn't hot anymore, you would put your hand on the stove, right? It does take time to get there.
Mm-hmm. So switching gears a little bit, what about for patients you see who are virgins? What about those patients who aren't having sex? How can this be helpful to them? And for maybe if they're not as comfortable with the internal work?
Good questions. So the position, again, that is it could be a wide group of people you're talking about. Women who have not had sex before, penile penetration, virgins, is if they're a pediatric patient, we do not do internal work on them. The definition of pediatric varies, right? So anybody who's under the age of 18, I do not see without an adult in the room. Okay. So you have to be okay with a parent or guardian in the room. If they're over 18 and a virgin, I will do internal work if they want with the approval of the MD. And that usually means that they've had a speculum exam with an MD. And side note, you guys should all be asking your MDs to do a speculum exam with a pediatric speculum. Okay. Side note. But women who don't want to do internal work, we don't do internal work. It's super simple. We can get to some of the pelvic floor muscles externally around the vagina, around the anus, around the sits bones. Some women just don't want anything to do, don't want me touching anywhere around their panty line or in that private zone, and we work around it. Remember, a lot of these women are having hip issues, back issues. We can also work on pelvic floor, right, relaxation without doing internal work, without even touching the vagina. A lot of it is behavioral modification and lifestyle changes. Can I tell them my favorite story about you?
Yes, you can.
Okay, my favorite story about Allison is we'd been working together for a little while, and we were starting to broach the topic of dietary changes, and yeah, that was her face, except with a little bit more FU in it. And she had came in, I'm just going to say it's a Monday, I have no idea what it was, and she was basically like, I ate a tray of donuts all day this weekend and I feel like shit and I just don't care. And she kind of gave me an FU look, and I was like, okay. I was like, that's great. Like, cool. You're an adult. That's the decision you made. It's my favorite story about you. One of my favorite stories about you. So it's about making those behavioral changes to help calm the nervous system, quiet the nervous system, and at least give that person tools to be in control of their pain. So if they are having a flare, then they know what to do. And I think giving you any of the control that I can give you helps at least make you feel like you're in the driver's seat of your life, your pain, and you can at least move forward and do things. And like, if you have a big event coming up, then you need to do your exercises and be really on your diet so you feel good moving into that.
Mm-hmm. It's a negotiation.
Mm-hmm.
It's figuring out what your limits are, what your triggers are, and negotiating around them. And, sometimes you say, yeah, I'm going to live with the consequences, but at least you figured out that connection.
Yeah.
And so that was something that I think PT was really helpful for.
Yeah. I don't eat dairy, but every now and then I really want some chocolate ice cream. And I pay for it that night and the next day. But like, some days I care and some days I don't.
Yeah. Okay, so we had one question come in that was, I've had 3 surgeries. Will PT still be beneficial for me? Or I've had X number of surgeries. Is this something that I can do? Is it too late to do? Is it still useful to do?
Yeah. Well, you've had X number of surgeries because you're still having problems. So yeah, absolutely. My question would be, what's going on? What are some of your symptoms? And absolutely, if you've never seen a pelvic floor physical therapist and you've had 3 surgeries, for sure. If you have seen a physical therapist, I think it's always worth a consult. I usually do about 3 or 4 visits with somebody before I tell them I can't help them, which rarely happens. Usually there's something else we need to work on if that's the case. But yeah, after 3 surgeries, you're going to have a lot of scar tissue. So at the very least, we need to address that.
What about someone who's going to PT and it's really painful for them? Is there a point at which that pain should that be painful? One, if it is painful, Is that going to stop at some point? You know, do things get worse before they get better? Should they just kind of tough it out, or is that something to be addressed?
Good question. Twofold, because I saw this question on the Facebook page, and I really started thinking about it. It is acceptable that pelvic floor PT is uncomfortable. So I always tell my people, if the pain is more than a 7 out of 10, we're going to back off. If your anxiety or your discomfort is more than a 7 out of 10, we're going to stop. It can be uncomfortable, but it shouldn't be painful. And if it's really painful, then you're just going to updrive your nervous system so much that anything or any muscle relaxation that you worked on during that last hour isn't going to help, because you're going to be in so much pain and you're going to be in a flare for like 2 or 3 days. And no, it's not worth it. Now, occasionally, if you're, or I don't even want to say occasionally, like every once in a while, I do work too aggressively by accident, and I do flare my patients. And it's like, oh no, we flared them. And like, that's the worst thing. And I always feel horrible that that happens. But every visit, that shouldn't be happening. And if you are flaring or it is really painful, you need to back up. Your physical therapist needs to back up and maybe find a backdoor entrance to that pain. Not literally the back door, but like if the pain is flaring the pain in your abdomen, then maybe they're not going to work in the abdomen. Maybe they're going to start in the hip, or maybe they're going to start in the rib cage. Find indirect approach. The other thing is, it's super important for you to vocalize that to your physical therapist. I promise you, we're people. We're not anybody special. If that pain, if you don't tell us that you flared, we won't know. We can't read your minds. And I always tell my people, I'm like, just shoot me an email the next day. Let me know if this flared you or not. Like, let me know how you feel. Even if, like, just shoot me an email, you won't be bothering me. And we can build and kind of tweak from there. Your reaction to our sessions is really how I guide what I'm going to do the next day. Like, if what we did helped you, let's keep going down that path. If it didn't, we have to try something different. And if it's flaring you, that's definitely not the way to go. The other piece is, I have to make sure that my patients are with me. So one of my questions in my questionnaire is, has there ever been an experience of sexual abuse, assault, trauma, verbal, physical? Because sometimes I find with some of my women that they disassociate a little bit if there has been a trauma. And that's horrible. Like, that's just a horrible thing that anybody would have to go through. But a lot of women will then say something like, just do it, just ignore me and just do the treatment. And I'm like, no, I can't do that. Because you're not going to get better. It's going to be a waste of your time and money if you haven't dealt with your trauma first. You won't be able to tolerate the internal work. It's going to be really painful. You're going to disassociate. And when you do disassociate, you're not going to be able to relax your pelvic floor. You're not going to be able to figure out what it feels like to have a relaxed pelvic floor. You're not really going to gain anything from this. So no. And at that point, we'll either only stick to external work, but really that's when I would like you to see a therapist and work through that bit first. If somebody really wants to see me, I will see you in conjunction with a therapist, but at a certain point, I'll say, I don't think this is worth your time or energy. And that's when I really, like, I'll look at, see that body language. If somebody is on a table and they're just kind of like staring through me, I'm like, no, like that's not what I'm going to do. And like, I guess in that case, I have the trump card to like say, stop. I don't know, but I think we have to address that, right?
Mm-hmm. Yeah, because you definitely don't want to re-traumatize patients.
Yeah.
And so much of what we go through having endometriosis is very traumatic anyway. There's a lot of medical trauma. And so when you factor that in with other kinds of trauma and just not feeling ready for PT, like, you don't want to do PT just because it's the right thing to do if you're really uncomfortable with it. I think it's a process of getting in the right place and being able to do the work.
Yeah. Some people, I know there's another question. Some people, I do work with them for like 2 or 3 visits with all their clothes on before we even talk about that. And that's fine.
Someone asked, how can you tell if you're having a flare episode?
Usually it means your symptoms increased drastically or your pain increased drastically. So if things were kind of moseying along and doing okay, and then they suddenly got really bad, you suddenly couldn't have a bowel movement, you suddenly had diarrhea, just, yeah, that's a flare. And it just kind of snowballs.
Right. So it's your symptoms getting worse.
Trigger is. Yeah.
How long do you typically work with patients post-excision or post-op?
Post-excision, sometimes it's like 2 or 3 visits. Sometimes it's 10 to 12. Sometimes it's more. It really depends. It also depends on your goals. I have some women who I see and they're like, look, I have all these things going on, but I only want to work on this one thing right now because that's what I have the bandwidth for. And I'm like, okay. Like this one woman I saw, she didn't have endometriosis, but she had pain with intercourse. And she didn't care about the intercourse piece because she was going through IVF. So she just wanted to relax her pelvic floor enough to do IVF. She didn't care about intercourse with her partner. So that was her focus. Like, again, it's your treatment and it's your goals that matter. My goals don't matter. It's really what you want to happen.
Right. Yeah. And I think that a lot of times we feel so out of control, you know, having this disease, not having a lot of options for this disease.
Yeah.
And I think one thing that has been really helpful for me doing physical therapy is having the feeling that like I have some control over my body. PT has helped me really learn to notice like where my pain is coming from. Is this an endo pain? Is this a scar tissue pain? Is this GI pain, rather than just sort of feeling completely out of control in my body that just feels so alien to me.
Yeah.
But also having that care team of somebody from week to week who is on your side and is keeping up with what's, you know, happening in your body. Because, you know, with a lot of the other parts of treatment with specialists, it's very impersonal just by the nature of it.
Yeah. I had somebody who I've been seeing for a while, and she kept complaining of like labial burning. And I was like, and she has endometriosis. And I was like, I don't think this is endometriosis. And we did a lot of manual work that session. And she felt better afterwards. And she was like, Karen, what did you do? And I was like, she's like, what did you do to the endo? And I was like, nothing. I think this is a pudendal nerve issue. I think, you know, I know you're getting surgery down the road, but I think you need to consider a pudendal block. And I gave her some names of some doctors and she did the research. She had a pudendal block and that actually made her pain about 80% better. So she actually canceled her surgery.
Yeah.
Sure if that's the goal, but like, again, I was like, okay, that's your choice. Like, she really didn't want surgery. And she said, since she felt so much better, like that was good enough for her at the time. Is that the ideal goal? I don't know. But like, again, I always say, like, you're the boss. I'm just here.
Right. You know, and I think that, I'm sorry, what?
You're cringing.
I know, I cringed a little. I know I'm a big believer in treating the disease, removing the disease, but you also have to remember that just because you have endo, that doesn't mean that endo is the only problem that you have. Endo isn't necessarily the driver of all of your problems. Sometimes it's a question of chicken and egg. Like, do I have this problem because I also have endo? And is this a comorbidity that's related to that? Or do I just have multiple things going on and they all need to be addressed and a multidisciplinary
And the chances
approach.
are we'll never know the answer to that.
Yeah.
But the question is like, where do you want to go first? Like we have all these different paths to pick. Where do you want to go first?
Right. And so is there any information that you know of on improved outcomes if you have PT before surgery versus after surgery, or is it really just ideal to have both?
There is no research study that I know of that shows that. That's a really good research project though. Somebody has to fund that and do that.
Yes.
I don't know of any research study that proves or disproves that. I would like to say that PT helps, but I'm biased, right? Yeah, I don't really have any more answer in terms of that. I do think surgeons are very quick to discharge patients. You have your 6-week, 12-week visit, and that's sort of it. And sort of like with postpartum care, I do think there needs to be like a 6-month checkup and like to tie up loose ends. But right now, surgeons don't do that. And I think just like a lot of other disease, there needs to be like a more multidisciplinary approach. We don't quite have that yet, especially with endo and excision, but we are getting there, but we're not there.
Great.
Sorry, that wasn't
it's always a work in progress. And then I think we need to go ahead and wrap up and hand it over to Maria to make our important announcement. But the last question I want to look at, is, for those who don't live in the Houston area, how do they find a therapist? For those who do live in the Houston area, the Endometriosis Foundation of Houston is working on compiling a list of physical therapists in the area who treat pelvic floor conditions, who have experience working with endometriosis. But for those who are not local, is there a way that they can look up PTs?
Yeah. The easiest one is to Google pelvic floor physical therapy plus your city. You can go on the APTA's website, the Academy of Pelvic Floor, or the American Physical Therapy Association, or the Academy of Pelvic Health, which is the subsection within the PT organization. Nancy's Nook is probably a good resource. But yeah, the thing you want to do is, I hate to say it, but it is a little bit of trial and error, right? In order to make sure that you have a good pelvic floor physical therapist, you want somebody that's going to question you, challenge you, and ask you questions and give you tough love, and also not just look at the pelvic floor, but also zoom out and kind of move around with you. Some red flags towards a not so great pelvic floor physical therapist is somebody who just puts you on biofeedback all day. For 45 minutes, they just have you Kegel, let go, Kegel, let go, Kegel, let go. Like, that's not good PT. There are some nurses that work in doctors' offices that do that and call it pelvic floor physical therapy. It's not. Also, if you have a physical therapist who's just having you do Kegels, that's not going to help you either. If you do the same thing every visit and like your homework doesn't change, that's not good either. And then also, if it always hurts, like, that's not helping you either. But a good PT should really kind of play detective with you, right?
Right.
You might have to kind of look in your community too.
Mm-hmm. Some websites that I think are useful for some people in some areas are Pelvic Guru,
Yes.
Pelvic Rehab. But yeah, I think it's trial and error. And, not every therapist is going to be a good fit for you. It doesn't mean they're necessarily a bad therapist, but, sometimes you have to find that right match. And that's part of, being in control. So one thing I want to do before we end, and Maria makes her announcement and does the giveaway. One One thing that can be really helpful that I learned from Karen, that can be really helpful for relaxing the pelvic floor, easing some constipation is, do you want to say it, Karen? So mooing. So if everyone, honestly, come on, you have to moo with us. So we're going to end
really deep.
Yeah.
I feel like the newbies don't know what we're doing.
That's okay. You're going to have to go back and watch the last video from the last talk. I will post it. Okay. So on the count of 3, even if you're on mute, I want you to moo. 1, 2, 3, moo. Okay, I'm sorry. I had to do that.
You know, we need to make shirts. We need to make t-shirts.
We're going to make t-shirts that say just moo. Okay, Maria, are you ready?
Maria.
Oh, you gotta unmute, Maria.
All right, thank you so much. All right, so if you have been following us, we emphasize the importance of getting excision surgery with a skilled surgeon. While excision surgery is the cornerstone of endometriosis treatment, it is one part of a multidisciplinary approach. However, this procedure, for a variety of reasons, is difficult for many of us to attain. The Endometriosis Foundation of Houston is excited to announce our pilot program called EFHou Pelvic Floor Physical Therapy Scholarship Program. We hope to ease the stress caused by the heavy financial obligations that endo throws our way. That's why we are embarking on a pilot program here in the greater Houston area. We will launch our pilot scholarship program in 2022 and will be accepting applications in January. For this pilot round, we aim to pay for up to 10 sessions of physical therapy for 2 scholarship recipients who will work with our trusted pelvic floor physical therapist partner, Dr. Kowenski. And we're starting small so that we can learn how to make this program bigger and successful. We hope this program will lead to other facets of endocare. So to stay up to date about the launch of EFHou Pelvic Floor Physical Therapy Scholarship Program, please subscribe to our newsletter and check out our website at www.efhou.org, www.fu.org. And one way to support the program is to donate on our website or PayPal. We hope you will be inspired to give us and to this worthy cause on the upcoming Giving Tuesday campaign on November 30th. Finally, I'd like to thank our hardworking board members for putting this program together, our volunteers and esteemed advisory board members for their support, our valued intern, Taruni Tangirala, for all of her contributions, and to Dr. Kowenski for believing in us and for partnering with us. We're so excited. And to everyone, thank you for your support, and we look forward to healing one Houstonian at a time. And now I am excited to announce the giveaway of this wonderful, beautiful planner. And the winner is Amy Miller. So Amy Miller, will you please message the host your information, and we will send you your own planner.
Yay, Amy.
Thank you so much, everyone. And thank you for joining us. We are so excited, and hope you'll tune in and join us next month. Allison?
Great. Thank you so much, Maria. We are so excited to be able to sponsor a couple of people to go through physical therapy next year. It's something that we've been working really hard on for a really long time. And so it's a huge deal. We're really relieved to be getting this off of the ground. So we really hope that you'll support us in this endeavor. And thank you so much, Karen, for joining us today. Thank you for everyone who submitted questions. Sometimes it's just nice to have a place where you can ask a bunch of different questions and not feel awkward about it, or like feel like you have to make an appointment and get a referral just to get like the basics answered. So thank you so much for taking some time just to sit and chat and answer a bunch of different questions with us.
Yeah. If you all have any questions, you can always email me, Karen@empoweryourselfpt.com. Best way to reach me. If you just want to ask me a quick question, maybe you were too shy to post right now, which is fine. You can always shoot me an email.
And I know that there were some questions we didn't get to. Sorry about that. We had a ton of questions coming through. So thank you so much for joining us. Amy, if you can go ahead and send me your email address and your shipping address so that I can get those written down and we can send you a planner. All right. Thank you for spending your afternoon with us.
Thanks for having us.
Bye. Take care.
Bye.